Good evening, everybody. Thank you for your patience. Today, we welcome our guest speaker, Dr. Rakesh Periwal, sir. With a rich 14 years clinical experience, Dr. Periwal is working as consultant intensivist based at Guwahati. Today, it's a pleasure that Dr. Periwal gave us some time from his busy schedule. Let's start today's discussion topic on HNFC, that is high flow nasal cannula oxygen. Thank you. Sir, please start.
The slideshow doesn't come, it will come on side only.
I'll just start the slide.
Okay.
Yes, sir.
Good afternoon, everybody. I'll be talking about high flow nasal cannula oxygen. It's a idea which has been there for long, but the interest in dedicated machines delivering them has started only recently and has probably picked up this COVID season. And we'll just try to tell you the idea and the applications. It's basically an oxygen delivering device, and it is delivered through a snugly fitting nasal cannula, so much so that it forms a very good seal in the nostrils. The cannulas are available in various sizes and should be chosen to fit the nostrils. And there is a flow generator which can give flows up to 60 liters, but that's by definition. Normal flow oxygens would be something like 16 liters, and above that up to 60 liters it is called high flow. Most machines that we have now give flows up to 80 to even 100 liters a minute. And there is an oxygen blender capable of delivering 100% oxygen at these flows. The blender is very similar to what we get in invasive ventilators. So what it means is that at flows of 80 liters per minute, you can actually deliver 100% oxygen. This device requires connection to the while mount compressor and oxygen unit. So you will need a compressed gas supply and a central oxygen system to run the unit. So it's not easy to take it outside the ICU. Most of the time you will be able to apply it inside the ICU with a compressed line. What is the need of these delivery devices? We have nasal cannulas, we have masks and high flow oxygen systems, NIV. Well, traditional oxygen delivery devices like masks cannot generate very high flows of oxygen because that is limited by the amount of flow which the system can generate. Generally 15 to 20 liters would be the max that we will be able to give. And although the closed circuits, or what we call as high flow mask, can give you higher FiO2s, but that never reaches close to 100%. And to make that possible, we need a blender which can give different levels of FiO2, and we can actually dial the amount needed in some quantum, generally present as 10, 20, 30, 40. So you can choose which percentage of oxygen you need, very similar to what we have in an invasive ventilator. Now, we know that in normal breathing, the peak inspiratory flows would be something like maybe 20-25 liters, but when patients are in distress, this can go up to 25 to 50 liters, and some patients in severe respiratory distress maybe up to 70 to 80 liters a minute. These flows cannot be matched by the flows which are generated by traditional oxygen delivery systems. And that is why when we desire to have high flow, high FiO2 during respiratory distress and to match it to all the inspiratory needs of the patient, we need a system which can generate high flow and can give 100% FiO2 at these flows. The HNFC is capable of doing that. So there we know that possibly we need it in patients who are in respiratory distress. The other thing is patients who require higher FiO2s, because we will be able to maybe have 40-50% FiO2 delivered by the traditional oxygen delivery systems. But there is another thing, which is heating and humidification. Now, this heating and humidification is desirable. We know that we normally, when we breathe at normal rates, our upper respiratory tract is able to heat and humidify the air. We need that air to enter into our lungs. Here, the temperature of the air which is delivered can be controlled. So you have an option of dialing in the temperatures. Generally, it's somewhere like 30 to 37 degrees Celsius, 37 close to body temperature, and 30 to 31 degrees a little away. And this range is given basically for comfort. uh, it has been seen that patients probably might be more comfortable with the temperatures around 31, 32 degrees Celsius. You can always ask your patients if they have any discomfort with the temperatures given. Otherwise, you can actually choose to give the flows at 37 degrees Celsius also. To maintain the temperature from the oxygen blender from the flow system to the mask, there is a special single limb connecting tube with a circuit present for heating. So what it does is the air through in the humidifier is brought at whatever temperature you have set, and the same temperature is maintained all throughout the circuit till the point of the nasal cannula, and the air enters the respiratory system at that temperature. The humidifier, the circuit, and the nasal cannula are the consumables here. So they need to be changed after each use. And the fixed part is the flow generator and the blender. And this heating and humidification is desirable with oxygen therapies, but this is not possible when we do it with the normal oxygen delivery systems. We know that at higher flows, we overwhelm the capacity of the upper airways to heat and humidify the air. So, and also during peak inspiratory flows, this high flow is transient, but when you have a system which gives a continuous flow all throughout inspiration and expiration, the body's capacity to heat and humidify the air is overwhelmed. And thus, you need an external system which can meet the needs of the patient. And what if we don't heat and humidify? Well, the problems are with cold and dry air. We all know that cold and dry air is detrimental to the respiratory system. The major problems with them are disturbances of the mucociliary function. The secretions may also become dry. These are likely patients who may have some secretions. They are all patients who have some kind of pulmonary disease. The cold and dry air also provokes inflammation. It can cause bronchospasm, all of which is not desirable. They also cause drying of the mouth and the upper airways. There could be crusting. The patients have tremendous amount of discomfort. And although the traditional systems do have these oxygens run over a container containing uh, normal water, it's just not enough to humidify. So you need a system which can provide heated humidification. We have used heated humidification so often in our invasive ventilators. Now we use HME more frequently. But anyway, we have realized the need for heating and humidification in oxygen delivery systems, not only oxygen delivery system, all flow systems. So even if the FiO2 requirements are less, and if we keep them at higher flows, the body's capacity to heat and humidify that air will be overwhelmed. And so, whenever we need higher flows, higher FiO2s, it is desirable that we have a heating and humidification system in place. We have used it in home devices, we have used it in devices used for obstructive sleep apnea, the Cpaps, and now we have a device in which we give high FiO2, high flow oxygen in the ICU. How does high flow help? Well, one is that it meets the demands of the patient. The peak inspiratory flow of respiratory distress would be very high, so those demands are met. The second, it also provides modest amount of PEEP. Now we know that these nasal cannulas fit in very snugly in the nostrils and they generate a very high amount of flow. So there is some amount of pressure buildup which is there in the respiratory system, and as a general 1 centimeter pressure buildup will be there for every 10 liters of flow. So if you're having something like a 60-liter flow, you can expect a PEEP buildup of around 6 centimeters of water. There is one thing which should be noted, that the patient's mouth should be closed at that point of time, something which is very difficult in patients who are in respiratory distress. They tend to keep the mouth open and inhale both through their mouth and their nostrils. In that case, the amount of PEEP which can be generated by the system is not great. So there could be loss of PEEP if there is mouth opening. Always consider that. This is something which does not happen when we have a full face mask, which covers up both the nostrils and the mouth. But then the whole idea of nasal cannula is to take away that face mask, make the patient probably more comfortable with just the nasal cannulas. The claustrophobia, the discomfort which is there due to the mask covering both the face and the nose is taken away by the just presence of a nasal cannula. And these patients can eat, drink, talk in between without removal of the interface. So they continue to get the high flows, high FiO2s. Of course, whenever they talk, they open their mouth, they eat, the amount of pressures which these flows generate is lost. So PEEP generation would be dependent on a very well-fitting nasal cannula, so there are no leaks around the interface, and also that the mouth remain closed when the high flows are being delivered. The PEEP is helpful in weaning patients from ARDS because we can generally wean them off when they have a modest PEEP requirement of around 5 to 6 centimeters of water, and in managing cardiogenic pulmonary edema. This is very, very important. In cardiogenic pulmonary edema, what we actually need is CPAP, some amount of pressures, and we need oxygen. The high flow system helps in both these. And how does the PAP help in cardiogenic pulmonary edema? Well, we know that whenever we breathe spontaneously, we develop a negative pleural pressure of around minus 5 centimeters of water with the effort that they make, and there is a negative intrathoracic pressure. Now you can imagine the patient making an effort and the lungs and the chest wall moving outwards, but whenever the heart contracts, it contracts inwards. So there is unfavorable transmural pressures exerted on the left ventricle. If we have positive pressures, then the left ventricular contraction is actually augmented. So that helps in left ventricular contractility. And number two is, whenever we have positive pressures inside the thorax, the aorta, the intrathoracic aorta part of aorta is also under positive pressure, whereas the extrathoracic aorta is at zero reference to atmosphere. So there is a gradient which is created now from the intrathoracic aorta to the extrathoracic aorta. So the pressure applications in cardiogenic pulmonary edema helps you with left ventricular contractility and also decreases what is known as the resistance because of a favorable gradient. This improves left ventricular output and should be considered standard. PAP application should be considered standard in the management of cardiogenic pulmonary edema. High flow system is one which can help. Also, you can use a CPAP with an oxygen flow. The higher flows also overcome upper airway resistance. This might be important in people who have some kind of obstruction to their upper airways, generally the kind of people who would have obstructive sleep apnea. The pharynx, the part behind the tongue, all this gives a lot of resistance, and this may be overcome with the higher flows that we generate with these systems. It also abolishes the dead space and fills it with oxygen. Normally, the dead space would be something like 100 to 150 liters. You can just put it as like 2 ml per kg body weight. So 100 to 150 milliliters of dead space is always there. This dead space would now be, all of it will be oxygen rather than being nitrogen or carbon dioxide. So it helps in the process of oxygenation. And here I would like to say that whenever these patients are on nasal cannula and you need to intubate them, they are already pre-oxygenated. So you can continue the nasal cannula and maybe intubate them with the nasal cannula on. This will also serve the purpose of pre-oxygenation. How NIV is similar or different? We have talked about flows, we have talked about pressures, how the upper airways can be opened, how PEEP can be applied, all of which we traditionally link to non-invasive ventilators. Well, if an NIV with a heated humidification system and a special heated tube, both of which are available, and we commonly use them with devices which are used for obstructive sleep apnea, and there is a nasal cannula, there you generally call them nasal pillows. It behaves similar to that of an HFNC, at least in terms of flow and humidification. But most of them would not have an oxygen blender, so the FiO2 delivery may be limited. Some of the newer NIVs also have oxygen blenders. They have the capacity to deliver accurate FiO2s. So maybe the newer generation NIVs and the HFNCs will be very similar to each other. But what is the difference? Where in NIV we set pressures which generates the flow, whereas in HFNC we talk only in terms of flow. So when you set the machine, then in an NIV you will be asked to set up a certain pressure. In Cpap, a single pressure, whereas in a bilevel or a BiPAP device, two levels of pressures, inspiratory and expiratory. And these will then generate a flow. They, if there is both IPAP and EPAP application, there will be a pressure support delivered with each breath. But in HFNC, we set only flows, and these flows are generally constant, which means that there will be a constant pressure generated by the flows that we have set. And I told you about pressures, around 1 centimeters of pressure for every 10 liters of flow. So in NIV, we can have bi-level pressures, and these can support the act of breathing. So an NIV can give you both positive airway pressure for PEEP and positive airway pressure for breath support. Whereas in HFNC, you do not get any support for your breath. What you get is PEEP. What you get is a little pressure to overcome the upper airway resistance. And that also is modest because flows of around 60 to 80 liters at the most will give you something like 6 to 8 centimeters of PEEP, conditional to the fact that there are no leaks and the mouth is closed. So we see that probably you can consider the HFNC as a kind of a CPAP device as well, which has the ability to give modest amount of pressure, but with the ability to give humidified, heated oxygen and oxygen concentrations which can reach up to 100%. So where do we apply them? But this COVID season, we have seen a new phenomenon, which is high requirements of oxygen, but not as much stiff lungs in fair number of patients. So any patient who is able to breathe spontaneously, who is not beaten down by the work of breathing, but requires higher concentrations of air, how much would be higher? Maybe 50 to 60% or more. They are the best candidates for high flow nasal cannulas. They don't need much support for breathing. HFNC would be considered ideal for them. Useful in acute hypoxemia, so you can use it generally when we wean these patients from ARDS. Sometimes maybe first up in ARDS, but in ARDS, most people would require some amount of support during therapy. So you need to choose a patient who has probably mild ARDS or lungs which compliance is not an issue, but the major issue is oxygenation. In ARDS, probably they are mostly used when we wean the patients off. It is not suitable for patients who have CO2 retention or COPD, where the work of breathing is an issue, or you need pressures to kind of ventilate the patient better. There you do not need, and we know that COPD patients do not require very high FiO2s. So they anyway are not candidates for high flow nasal cannula oxygen. So it's basically applicable to people who require higher flows of oxygen, who may just benefit from the PEEP which is applied, either the PEEP for cardiogenic pulmonary edema or for non-cardiogenic pulmonary edema. and maybe modest amount of PEEP, which can help some patients with obstructive sleep apnea who land up in the ICU and require oxygen, and patients whose work or breathing is not an issue but require a higher FiO2. These are the major people who have the need for HFNC, and we are seeing a lot of these patients now, especially with COVID, where we find the compliance is not an issue, but the FiO2 requirement is high. So HFNC is basically used for these people. This is all I had to say about the device. I'm running a short video to give you a demonstration about how the device looks, and managing it, learning the actual application of it is very, very easy. You can easily learn it just in one demonstration. Maybe this small video will also help, and your staff can also learn. There are only two things to regulate. One is the FiO2 and other is the flow, and both can be independently regulated. So you can choose according to your needs. Well, I'm just
Start
showing
the
you, yeah, the humidity is the how the water is transferred to the humidity chamber, and how you can set the temperatures, the flow and the oxygenation dials, and then the tubing, which is connected to the nasal cannula. The assembly is very simple, very similar. Just it's a new device. At least for me, it's a new device. We have started using it this season. So I just wanted to share the real physical part of the system. Here we have a high
Yeah,
flow
now I can
nasal
play.
oxygen system. You can see that there is an oxygen blender, and there is a dial which you can rotate to the desired FiO2 going up to 100%. And then you have a flow generator by the side in which you can keep flows of up to 80 liters per minute. Both of them can be independently regulated. The oxygen and the compressed air comes from the wall mount unit, just like in invasive ventilators, and they go into this blender and flow generator unit. And from here the oxygen goes into the heated humidifier chamber, in which distilled water is delivered through an overhanging bottle of distilled water. This generates heat and humidity, and the heat can be regulated. Here we are delivering at 36.5. Keep it close to, you can keep it away if there is any discomfort, starting somewhere like 31 to 32 degrees. And then from here, a single tube comes, which is a special heated coil, and goes into the nasal cannula, which fits snugly in the nose of the patient. And this is the connecting point for the nasal cannula. Yeah, that was the
Yes, sir. So one question is there already.
okay.
What is the initial setting and how to adjust the flow and if I O2 after initiating therapy?
Okay, the FiO2 delivery would be dependent on the SpO2 levels. Regarding the flow, if the patients are in distress, then we generally start at very high flows. May the highest which the machine can give, something like 60 to 80 liters. Because whenever they are having distress, they generate a lot of inspiratory flow. So in that case, we like to keep them at higher flows, maybe 60 to 80 liters. It's slightly noisy, as you could hear in the video, and then we come down on the flows if the distress of the patient settles down. Since the flows and the FiO2s can be regulated independently, you can make your own permutations and combinations. But I would suggest that please keep the flows high, because most of these patients would benefit from some amount of PEEP which the flows generate. So the flows not only allow higher flows of oxygen, but can also help in generation of modest amounts of PEEP, something like 6 to 7 centimeters of water.
Okay, sir.
Or somebody can share their views also. Anybody who is using, how good or bad they are finding.
One person wrote that nice presentation.
A lot of people have
Any
waited. Oh,
factor that
somebody.
one person is asking that any factor that limits high flow, Dr. Surendra.
Or the comfort, because we are using HFNC over NIV, let's say, only to take away the sense of discomfort. We know that the higher flows, the patient also has to exhale against those high flows. The high flow is constant, it's not different during inspiration and expiration. So some patients may have a little bit of discomfort because of higher flows. If they complain of discomfort, then obviously you have to cut down on the flows. But otherwise, just like with NIV, if we can kind of slowly build up the flows, maybe start with something like 30, 40 liters and then build it up over 5 minutes, maybe to 50, 60 liters. Of patients who have intolerance to flows, maybe we will be able to manage. Because we know that the modest PEEP application, both in cardiogenic and non-cardiogenic pulmonary edema, actually also improves the work of breathing for most patients. So counseling them is very important. Some of them really feel a sense of discomfort when we just put in the cannula and start the high flows. That is true. So maybe just begin, just like we do it with NIVs, begin with a lower pressure. And maybe in this, it's very easy. Just rotate the dial and keep increasing the flow, keep talking to the patient and see that they are comfortable with the higher flows.
Dr. Deepjyoti Das is asking, so we have to access clinically or should we be guided by ABG?
Or ABG also. I said, whenever you are in doubt about the work of breathing issues, then be guided clinically, look at the heart rate, the respiratory rate, and then in the ABG is a major thing to look at is the carbon dioxide level. That gives us some idea about alveolar hypoventilation. And here it would be related to the effort. So if you think that the patient requires actually support with breathing, then you need a bi-level pressure. So it's more like a CPAP, whereas whenever you have the indication for giving BiPAP in any patient, then you should switch over from the nasal cannulas to some other oxygen delivery system, which is basically non-invasive ventilators or invasive ventilator.
Yeah. Dr. Deep Das is asking, what are the issues we should be careful of?
The cannulas going out, that is one thing which happens because these patients are very conscious, alert. The cannulas are just snugly fitting, but there is nothing to fix them. And so patients may sometimes put in their hand somewhere on the face and take the cannula away. This we see very commonly. So the patient also need to be told, and maybe we can put in some tapes around the areas where this nasal cannula fits to kind of uh, tether it to the body, keep it there next to the body of the patient. Otherwise, I think that is a major problem. The other issues are not there. There's hardly anything to set and kind of tell the patient. It's just like an oxygen therapy, except for the fact that the patient will have higher flows. It's very similar to what is we do with the normal nasal cannulas with oxygenation, but there the flows are modest, 10 to 15. Oh, the nasal cannulas maybe 5 to 6 liters. This is what the oxygen delivery that we generally give. But with this, there will be much higher flows. So that is the only thing you should be careful about.
Okay. Dr. Sherin is asking, should the temperature be kept constant at 36.5 only, or
Okay,
does it need variation?
there is a very beautiful trial on it. What temperature is basically chosen to keep it near to body temperature. So best would be something like 35, 36, 37. 37 I think is the max you can set. But the problem is when this kind of temperatures are delivered to the nostril, which we are not used to, at such high flows, then the patients start feeling discomfort. So whenever there is a discomfort, the temperature should be brought down. I think most and the trials which HFNC have shown that there is greater discomfort with temperature rather than with flow. And in that case, probably keeping them at something around 31, 32 degrees to begin with would be better. So lower temperatures are more comfortable to the patient, but you can always ask. I had shown the video in which I had set a temperature of 36.5. My patient was absolutely comfortable. There were no complaints. No complaints, keep it to near 37. If there are complaints, keep it further away from 37.
Okay. Dr. Shubhadeep Pal is asking, is there any high flow related to volley trauma?
Oh, generally not, because I think the flows are basically not as transmitted. I said you very modest flows for 6 to 8 centimeters of water, or hardly, and there's a constant. So you basically have what is known as the functional residual capacity of these stiff hypoxemic lungs would be improved. So that improves a little bit of work of breathing. But volutrauma or barotrauma, no, they are not seen with HFNCs.
Okay. Dr. Nilotpal is asking, so flow is depend on FiO2.
No, no, both can be independently regulated.
So you are answering that flow is depend on FiO2 now.
No, no, both are independent.
Okay. And the next question, Dr. Sheikh is asking, I have Airvo HNFC. I use it for neonates and pediatric patients.
Yeah, we are learning it from pediatricians only. They say, is it like bubble CPAP? Oh, yes, very much similar. You can use this
So we
in
end up
children.
disposing many cannula. He said so. So is there any way we can reuse the cannulas?
Oh, no, it is not recommended, but the cannulas which I have seen are very difficult to clean as well. And interestingly, when you buy the consumable set, they all come in one pack. So it's very difficult just to get the cannula. There is a consumable expense Indian markets around 7 to 8 thousand with each set. So that is one problem, that you have a expense which is much more just than the cannula. The tube also comes with it. Otherwise, you can try actually the nasal pillows, which are used for patients with obstructive sleep apnea. They fit to the tube also. They are very easy to clean. They have different sets as well. They also come in 3 different sizes in one set, and you might actually consider to using them. We have not used them, but I'm definitely going to explore that. But if you ask me if there is any instruction how they can be cleaned, well, there is none. So it's all the jugaad kind. Or we use, yeah, we can clean it with soap and water. Soap and water cleaning is recommended for most home-based nasal pillows, which we use for OSA. So you can apply the same here as well.
Yeah. So Dr. Shubhadeep Das is asking, what is the advantage of a NIV apart from comfort?
Apart from
Comfort.
this is basically a CPAP, you can call it. An NIV would be definitely a different device. It would be more like a ventilator, whereas HFNC should be considered more like an oxygen delivery system only. So the two systems are very different, except for the fact that both generate flows, both have a non-invasive interface, both can be delivered by nasal interface, both are capable of generating pressures in the airways. But with HFNC, there will be a single pressure, modest amount, whereas with NIV, you can give 20 to 25 centimeters of pressure. The most of the bedside machine would allow, and many patients tolerate 20 to 25 centimeters of pressure, which we generate with NIV. So when you need NIV, HFNC will not help you. HFNC is not going to support you with the work of breathing.
Yeah. So Dr. Deep Das has given his views that because of high flow, any trauma to nostrils, dryness, etc., patients are complaining.
Yeah, can happen. Can happen. This is actually the physical part of the therapy, not because of the flows, but probably because there is a nasal cannula which really goes inside the nostril. Yeah, there could be some amount of pressure sore and injury. This is same as we use with any interface. Any interface, whether it's an ET tube, it can cause pressure sores on the lips, corners of the mouth. Your face masks and nasal cannulas can cause sores on the face and the nose. And this can also produce a sore because we want it to fit very snugly, very tightly. But otherwise, there are no problems. The problems of nasal drying, which are there, are not seen here because of heat and humidity. So that is almost taken care of.
Yeah. So Dr. Shashi Ranjan is now asking that what will be the indication to shift patient from nasal cannula to BiPAP, and after how much time of nasal cannula we can do ABG?
Okay. I think with the nasal cannula, you're looking at the SpO2 continuously. So saturations you can track. You can do your blood gases at whatever intervals you desire, maybe an after hour, 2, 3. That is on to you. Because at the time of choosing the patient for HFNC, you have already convinced yourself that my patient just requires higher oxygen, but it does not require a lot of support. If you're feeling that your patient is tiring out because of the work of breathing, although he's able to maintain oxygenation, but his respiratory rates are going higher, his distress is not getting relieved, his tachycardia and tachypnea is persistent, then probably it's time to switch over to a ventilator. Whether it's invasive or non-invasive is a choice that you make.
Okay. Dr. Deepam Sharma is asking if a patient mouth breathes, does it makes the system ineffective? Can
Little
patient
bit,
exert through
little
mouth?
bit. It will not cause so much loss in oxygenation, but it will cause loss in the PEEP which the system can produce. Yes, there is no quantification. And the other thing which happens is when the mouth are open, because the air enters through the nostrils and some amount can exit through the mouth, the patient can have some amount of discomfort because of this also. So uh, there is loss of pressure, maybe modest loss of flow, not much. FiO2 loss would be very minimal, but yeah, PEEP will be lost. Maybe I don't know how much, how I can quantitate, but PEEP loss will be there.
Okay. So Dr. Deepjyoti is saying that his patient complained about heated air at temperature of 31.
Oh, then there is you can go down even further. I mean, the problem with going down more further is then you leave it to the body to heat the air. So something like 30, 31 degrees is the least that you can go down to. The machines allow you to go to lesser than that also. I have seen patients being given HFNC as 28 degrees also. But then the idea of heating is actually lost. Our ICUs are already at 24 degrees. So the air is already 24 degrees. If the 24 degrees 20 is that what you give with an HFNC, the temperature, then probably there is no point in heating the air. The air is already heated to that much. So I would say don't go below 31 degrees. At least keep it there. Do not leave it too much for the body to do it. Do it externally, deliver it. Yes, keep coming down. If the patient persistently complains, then it's okay. Then you can keep coming down because patient comfort is very important. They are awake and alert and they are distressed. They don't want any further distress to the system. So you can keep talking to your patient. I think most people can be convinced.
Yeah. Okay. So no more questions, actually. So, okay, we can close it here, sir.
Yeah,
If
we can close it here.
yeah. Okay. Thank you, sir. Thank you, everybody.
Thank you everybody for joining. Thank you
Yeah.
for all the involvement, and we'll catch up soon.
Yes. Thank
Thank
you.
you so much.